Oxygenation, airway, respiration, and ventilation. AHA guidelines recommends that patients with suspected acute coronary syndrome, ACS, or stroke do not receive oxygen unless SpO2 is less than 94% on room air, if the pulse oximeter is unreliable or not available, oxygen should be administered. The patient complains of dyspnea or has signs and symptoms of shock or heart failure. Oxygenation of chest pain and stroke patients. 2 liters of oxygen per minute via nasal cannula should be administered for patients who complain of dyspnea, experience signs and symptoms of shock, experience heart failure, and have an SpO2 of less than 94% on room air. Titrate oxygen should be used to maintain an SpO2 of at least 94%. Effect of ventilation on venous return and cardiac output. In the normal patient, the negative pressure that causes inhalation facilitates venous return necessary for adequate cardiac output and perfusion. Cardiac output is the amount of blood ejected from the left ventricle in 1 minute. Cardiac output is equal to stroke volume by heart rate. Stroke volume is equal to the amount of blood ejected from the left ventricle with each contraction. The heart rate is equal to the number of times the heart contracts in 1 minute. Negative pressure during inhalation allows venous blood return to the right side of the heart, which is necessary for adequate cardiac output. Artificial ventilation pushes air into the chest, which is positive pressure ventilation, increasing intrathoracic pressure. Death by hyperventilation is a common and life-threatening problem during cardiopulmonary resuscitation. It increases in intrathoracic pressure, which impedes venous blood return to the right side of the heart. Excessive ventilation rates during positive pressure ventilation decreases cardiac output and decreases vital organ perfusion. For adults, artificial ventilatory rates greater than 12 times per minute, which is 1 ventilation every 5 to 6 seconds, decreases cardiac output and perfusion. Do not exceed a ventilatory rate of 10 to 12 times per minute, which again is 1 ventilation every 5 to 6 seconds. High artificial ventilatory rates, which is greater than 12 times per minute, results in poor patient outcomes. Tissue damage may increase when A. High concentrations of oxygen are given to ACS and stroke patients. 1. The oxygen releases free radicals, therefore it is no longer recommended. 2. Free radicals, byproducts of metabolism, are toxic to neighboring cells, destroys their membranes, and causes increased local tissue damage. Reintroducing high concentrations of oxygen to cells that have been functioning anaerobically increases the production of free radicals, causing cell membrane damage and tissue death. Lastly, delivering high concentrations of oxygen to ACS and stroke patients may be more harmful than keeping the patient on room air.